is Lisa Piscatich. I am the Health Promotion Supervisor at the Missoula County Health Department, and I oversee the prevention programs around behavioral health, substance use, chronic disease, worksite wellness, traffic safety. And really to shift those behaviors, we need to make sure that we live in an equitable community for all, so everybody has access to all, to affordable, accessible, quality, and safe, what we call social determinants of health. So education, income, air, water, transportation, housing, and the list goes on and on. So with that said, today you have signed up, or you didn't RSVP, which is totally fine, because I didn't ask you to, because we were trying to make this organic. A cultural humility training with Dr. Sharon Smith from the Missoula Urban Indian Health Center at the University of Montana. She's having some car trouble, so she's running a few minutes late. So we are going to do a little introductory piece of another part of health equity that we are working very hard with, creating a inclusive, equitable community within city county government and the health department as a whole with my colleague, Hallie Carday. And so I just wanted to start to introduce you to a concept around introducing gender equality in our work, or gender equity. I'm not sure the name of it, what to call it, but
yeah, it's really identity equity.
Identity equity, there you
yeah,
go.
We'll just call it.
Yeah. So I'm going to let her just do a little intro piece while we wait for Sharon. So
yeah.
We're being flexible, and I just want to thank you for being here and carving out the time in your really busy schedules to build cultural humility and into the work that you do, and I just really appreciate you being here. So thank you.
Yeah, so hi everyone. I feel like I know now, after a few months in, know most of the people in the room. Some of you I still have to meet. My name is Hallie Carday. I'm the new coordinator for health equity. I actually had the opportunity to work with Dr. Sharon Smith at the Missoula Urban Indian Health Center before coming into this role. So I'm really excited for y'all because it's going to be a great presentation. But yeah, so slowly working our way through the health department, sitting with different divisions to begin health equity training, taking this huge abstract concept and distilling it into tangible things that we can apply to our work, so that we can shift our own mindsets, work within our own identities to create a culture not only within Missoula City County Health Department but across city county government, and working with our community from a place of equity and recognition of all identities, and truly creating inclusive space, because we hear things like diversity, equity, inclusion thrown around a lot, but what does that really mean? And honestly, a lot of that begins with work, internal identity work. So one of the things that we've taken that is a practical application to some of the meeting spaces, whether intra-departmental or within or external facing to the community, is a concept of how we set up our meetings, and are we creating inclusive space with the way that we're doing things as simple as introductions in our meetings. And so one of the things that's come, you might be sitting amazed and this has already happened, is that people are introducing themselves with their pronouns. Now, I want to be clear that non-conforming, and that is to speak to non-conforming gender identities. I want to be clear that non-conforming gender identities are not a new concept. You know, they've existed as far back as history goes, but this practice may be new to some people, and we want to meet people where they're at in terms of their comfort and understanding of why we do introductions that way. But we want to recognize that there are people who exist in our community and exist even probably within this workspace that do not conform to the standard gender identities of female, male, and that someone may present as female to you in your understanding of what female is, but may prefer to be called he, him when they're not in the room. So that's a simple way that we like to distill talking about pronouns, is that it's just what you want somebody to call you when you're not in the room. That speaks to your true identity. And by doing something seemingly simple as introducing ourselves with our pronouns, it allows us to create a space, even if nobody in the room identifies outside of that our general constructs of gender. It creates a space where if there were somebody still struggling with that identity, still figuring it out, we've created a space where they know that they can show up with that whole self and be met and sit at the table as an equal. And so that's part of equity, is investing that extra bit to identify parts and people in our community that have not previously received that recognition or investment. So with that said, my name is Hallie Harday. My pronouns are she, her, hers. And I know it kind of sounds like you're going back to grammar school, so you don't have to do all of them. A lot of people just do she, hers, or he, his, and you could just say she. But we want to be clear that some people are she, her, hers, some people are he, him, his, some people are they, them, theirs. And yeah, so if we want to take a stab at it, and again, this is an open conversation, right? People are at different levels of comfort and understanding with this, and equity is a huge part of what's happening with reaccreditation, and it's written into all of our domains. So Mary and I, I've been so fortunate to work with Mary and starting to roll out these trainings and conversations with staff. It's an open door, and we want to have conversation. We want to answer questions. I don't want to present anything as like hard and true fact, but just be transparent about where we're trying to move as a department, and hopefully as a whole community. And that means bringing everybody along and having thoughtful dialogue and answering difficult questions about what this means. So please know that our doors are always open, just as semi-representatives of this work, to answer and engage with you in dialogue. Yeah, so anyone want to begin? I figure we could just go around the room and use this time to get to know one another before Dr. Smith comes.
Go ahead.
Sure.
Bridget O'Connor, she, hers.
Oh, and if you just want to share like what you do too as well, that's probably helpful for me.
In the basement.
Okay.
Steve Schmidt, he, him, his, and I'm the DUI Task Force and Buffalo, Montana Coordinator.
Maura Jones, I'm the Community Health Specialist with Health Promotion.
Nancy DePastino, she, her, hers, Suicide Prevention Coordinator.
Adrienne Hopkins, she, foster grandparent volunteer coordinator. I have a question.
Yeah.
I don't know much about it, so I just want more information about people identifying as plural.
As it's also a singular.
It is, yeah.
That they is.
Mm-hmm.
It's, yeah. So I don't know if you want to.
Sorry.
Sure.
This has come up in like technical writing as well, where I've gotten pushback, but it's now seen as also a singular or a plural, depending upon the context. And interestingly enough,
I know.
The word of the year, because we're coming towards the end of the year, so it's like, this is the year in review. Merriam-Webster, the dictionary, we probably don't use the book anymore, but we go online and maybe check things out. The word of the year is they. And last year it was justice. And they'd said that they selected the word they this year as kind of an acknowledgement of how there's really just this push towards equity and identity. So it is both singular and plural. So if someone is gender non-conforming, like if they don't feel, maybe they're gender fluid, so sometimes they present more as male and sometimes they present more as female, but they don't really fully identify with either one, they might want to be they. Do you happen to watch Queer Eye? Okay, there's a human being on there who, identifies as they, them. That's why I was asking and trying to think of if I could find like a cultural reference for you to anchor into.
So someone who felt like one person, why would they say they for them? I mean, if it was singular, like you were saying.
Because there's no other option right now. Do you know what I mean? It's kind of the way language evolves.
Or if they're not he or her.
If you're not he or she, right now the only other pronoun that exists is they. And so I would say until language evolves, those are going to be the three categories that we use.
Because that is a linguistic challenge of many decades when you don't want to say it's all him or her.
Yeah, absolutely.
And when you're in writing and
yep. And I mean, it makes sense why we
he or she, because it's unwieldy.
Yeah, and it makes sense, like, as humans, in order to function in the world, we need to put things in categories. Otherwise, we'd be like incapacitated and still in bed, probably. That's just like how we have to move through the world. And it's also, how we track data. And so that's why it's going to be a slow shift. But that's kind of why there's a whole group of, we don't know a lot about, for instance, trans individuals, because there's been no category that they fit into.
I imagine other languages are having probably even a more difficult time than the English language. Do you know anything about, like, Spanish, for example, that has a very,
Gendered.
masculine, feminine?
Yeah. I know there's like talk in that community, Spanish language community, all encompassing around the world, about how would that look, as a language change, like getting to neutral conjugations, and that's obviously super difficult because in Spanish, things are gendered, so like the door is female and the cat is male. So that's a tough. But I think I just perfectly saw a headline the other day of an article that I meant to revisit. But this conversation is happening across culture, across language. How do we take something as basic to people as language and make it more inclusive? And so we use what we have right now.
Did that answer your question?
Yes, thank you.
Sorry, I just got really excited. So
That was Mary excited.
Sorry, that's me getting excited. Mary, and my pronouns are she, her, hers.
I'm Susan Bucher. I'm the billing specialist here at the Health Department. I'm a she, her.
Good morning. I'm Eat Smart Missoula coordinator here at the Health Department. I'm she, her, hers.
And I'm Hannah Fields. I'm a substance abuse prevention specialist and the Connect coordinator, and I'm she, her, hers.
Ellen Leahy, the director, and she, her, hers.
I'm Courtney Chase. I'm the diabetes prevention program coordinator for that, and I go she, her, hers.
I'm Ivy Anderson. I'm the program manager at the Parenting Place, and she, her, hers.
I'm Colleen Morris, and I manage the immunization clinic here at the Health Department, and my pronouns are she, hers, and her.
Amber Rogers with Mountain Pacific Quality Health. I do quality improvement for the clinicians, and she, her, hers.
B-Rad Applegate, public health nurse and infectious diseases, he, him, his.
And this is wonderful timing because Sharon has arrived.
Thank you so much, everyone. And again, questions are always welcome if it's something you want to sit with for a little bit, or something that pops up to you, like, hey, I interacted with this person in the community and have a new question.
Yeah, and I really appreciate that you asked that question.
I know, it's brave to ask when we're talking about fairly concepts that are sensitive and maybe new to people. Yeah. So, thank you so much. And I'm looking forward to continuing individual and collective conversation with all of you in the future.
And I can share, we've been trying to model the gender identity work at our meetings and setting the stage and facilitating our meetings. And Hallie put together a list of resources that I can share with you on your email when you sign in, if you all would be interested. Yes? Okay. Thank you. And we can pull your presentation up. Okay. Well, why don't I do that, and you can introduce yourself.
Yes,
and I would just say I want to thank you for being here, Dr. Smith, and welcome to the Health Department. And the stage is yours.
So before we begin, this is the bathroom.
Yes.
Perfect.
Yes.
Okay.
Does that work?
Yep, that is. I can talk as long as or as short as possible. So my name is Sharon Smith. I am the Gunny Blackfoot from Alberta, Canada, and I am Suchambu Rosebud Sioux from South Dakota, born on the Rosebud Sioux Reservation, and that is in the south central portion of South Dakota. Now, today what I will be talking about is in the Indigenous Lens, really stepping into my own background and also the experiences that my family and I have had as we have navigated not only the healthcare system, but also through my work with the School of Pharmacy. I am a clinical assistant professor at the State School of Pharmacy on campus, and part of what I do there is preparing our student pharmacists to roll out into their experiential education in different practice settings that include Indian health services. And so part of what we do is we help to incorporate cultural humility training as well as some basic awareness of the history of our Native people and how it shapes us today. The other place that I work is Missoula Urban Indian Health Center, and that is our local urban Indian health program of 41 and growing plus urban Indian health programs across the United States. These are nonprofit facilities that are contracted through Indian Health Services, and they are legislated through Congress. So what I'm going to do is just sort of give you a beginning journey. But one of the things with we as Native people is that we are really place-based. When we look at how we view the world, oftentimes it is very much connected to our land base. And so here in Missoula, one of the things that I would like to acknowledge is that this has been a homeland for thousands of years for our Native people. And at this time, I'd like to acknowledge that the Salish people considered these lands right here as their homeland and continue to be a significant presence in the day-to-day lives that we live and interact with here in Missoula. So the title of this is called Walking Well in Cultural Humility, Contextualizing the Healthcare Journey and Redressing Power Imbalance Through Indigenous Lens. And I will acknowledge that even though I have been in academia for over a decade, I still struggle with technology. So if I accidentally go backwards, please forgive me. So one of the things that we will do today to really delve into that cultural humility piece is to actually help to walk you through how it might feel as a Native person, and then also as a healthcare provider, how we can do some self-reflection in being able to identify where our lens versus the people that we interact with may differ, but not only how they differ, how we might be able to bridge those differences in how we interact. So one of the things that I know has been very difficult in working with our students at the University of Montana, as well as different medical residents and healthcare professionals just across Montana, is how do you help convey an understanding of how the historical context of the things that have occurred amongst our Native people and the federal government. Why is that still so much a part of our conversation today? Why is that important, and why isn't it something, as sometimes I'm asked, well, that's really sad, but why can't we move on? And a lot of that has to do with the fact that these historical stories that have taken place have been integral in how policy has shaped the lives of our Native people today. And not only that, but where we are today as far as the health inequalities of our Native people. So my hope is to redefine our relationships between our individual roles and the people we serve. And that's through a model of learning, which is what we'll be doing today, understanding and reflection of what I go over today. And that's to help prepare us as individuals working in the healthcare field to better advocate for and support our tribal communities in accessing and navigating the healthcare system. And by doing so, the hope is that we affect change through that process. So the first thing I always do is just go over a basic understanding of health disparities. And so this particular quote comes from the Office of Disease Prevention and Health Promotion, the Healthy People 2020 publication. So a particular type of health difference that is closely linked with social, economic, and or environmental disadvantage. Health disparities adversely affect groups of people who have systematically experienced greater obstacles to health based on their racial or ethnic group, religion, socioeconomic status, gender, age, mental health, cognitive, sensory, or physical disability, sexual orientation or gender identity, geographic location, or other characteristics historically linked to discrimination or exclusion. So even within an hour, it's very, very hard to really delve into the whole global context of where we are with our American Indian health issues. And so I'll just touch on pieces of those, and know that I'm always a resource if you have any questions as we finish up today. So for our Native people, part of the health disparity contributing factors we know and acknowledge include historical trauma, poverty, isolation, and underfunding, which continues. And our overall goal is to improve those health outcomes and close the gap on the inequities. And so understanding what the Healthy People 2020 goal was, health equity is attainment of the highest level of health for all people. Achieving health equity requires valuing everyone equally with focused and ongoing societal efforts to address avoidable inequalities, historical and contemporary injustices, and the elimination of health and healthcare disparities. So when we talk about cultural humility, there is a goal, and that goal, once again, is to improve those health outcomes. Understanding that here in Montana, we definitely have gaps when it comes to our Native people, understanding that even with our life expectancy, while there have been small gains, we have a lot more that we can do if we all have an understanding of what some of those barriers are, some of those challenges are. So I often will use the life expectancy in Montana, and does anyone here know, besides Hallie, what that gap is for our men and women? Okay. So in 2013, when the state health assessment came out, then the gap was 19 years for men and 20 years for women. This last publication that came out last year, we have closed the gap. However, that is still marginal. That gap is now 16 years for men and 19 years for women. So there is an incredible amount of work to do. Yes?
Do you mean between non-native and native?
Yeah, so let's clarify. So that is the age, the mortality rate for our men is 16 years less than non-native men, 19 years less than non-native women for Montana. Okay, and that includes the Missoula area. So this is a picture. I like to be visual as a Native person. Not only are we storytellers, but visual is very much a part of our culture. This right here is my auntie mom. So as part of Native people, we deal with loss frequently. And so our extended families often become our parents, and that's how we look at them. So my father's sisters become my mother's, and my father's uncles become my father's, and vice versa with my mom. Her sisters and brothers also become parents for me. I lost my father when I was 10, and so my aunt became very much a part of helping raise me. But this last summer in Browning, Montana, one of the things that we did is we got together, and that's a picture of her in front of our family's teepee. That particular teepee design goes back several hundreds of years. And we have continued to pass that down through ceremony from one generation to another. When I look back, this is actually my grandfather. So George Kicking Woman, Doris Kicking Woman. My grandfather was alive in the turn of the century. And you can see him here with my daughter. That is my youngest daughter, Olivia. That's a lot of information, a lot of knowledge that we had direct access to throughout my growing up. And when we grew up in the same household with grandparents, aunts and uncles, siblings, all living together. This is in front of our house. We call it Fort Kick on the Blackfeet Indian Reservation. And the same thing with my mother's side. My mother's side, who was Lakota, growing up with great-grandparents, grandparents, aunts and uncles, all in one house. So these are my mother's great-grandparents. And when I grew up with their children. They were my great-grandparents. And we heard firsthand stories from them on how things had affected them. I grew up a lot with the stories of them traveling to Washington, D.C. To sign various different treaties that have shaped who we are today and how we receive health care, but also how laws affect us both on the reservation and within the healthcare system. This is my great-great-grandmother on my father's side. So she is right around the Star School area, which is right along the border of Montana and Canada. But what this is here to depict is that oftentimes when I hear that happened so long ago, it really did not happen that long ago. This is firsthand knowledge that we've been receiving throughout my life and my children's lives. So the time frame of when we lived in these cabins here only missed one generation. So my aunt grew up in the same cabin. And in fact, when my daughter was this age, that is when we as a family took down that one-room dirt floor cabin on the Blackfeet Indian Reservation. One of the things that I like to acknowledge as well is the different tribal territories in Montana. You can see that we have the Blackfeet and the Gros Ventre up here. We have the Pend Oreille and Salish down by the Missoula area. And you can also see on here the tribal names that we call ourselves. And those tribal names often also reflect who we are as people connected to our land. So for the Blackfeet, the Niitsitapi really means first people. And it really does tie to the land base. As a Lakota woman, Ikje Wichasha, so that's people of this earth. Once again, really depicting that land base and that connection that we have. For myself, I will say that I have been migratory my entire life. So as a Native person, with my father being born in Canada, and my grandparents lived right along this border, just the border divides our family. So half of them live in Canada and the other half live here in the United States. Part of what my life consisted of was a lot of migratory traveling with the seasons. So my dad actually would bring us to the Missoula area in their summer times where we worked the ranches and the orchards, all the way from St. Regis to the Flathead, all the way up to the Bitterroot. My grandparents talk about how they traveled through this very valley in the early 1900s and traveled up to the Bitterroot in a wagon to pick sugar beets during the sugar beet harvest season. And then they would talk about the days of travel. It took about a week to go from Browning to the Bitterroot as they stopped along the way visiting. But once again, not very long ago. But also understanding that, so my mother's people the Sioux here, I grew up hearing my grandfather talk about riding on horseback from the Blackfeet Reservation, going all the way as far as Crow, because they still had Crow raids all the way up to the Blackfeet in the early 1920s and 30s. And so it's really interesting to be able to really embrace how much has changed from then to now, but how it was only one lifetime ago that these things occurred. So I often like to begin with just sharing the history behind our urban Indian health programs and why we are here today in Missoula. So prior to the 1950s, as Native people, we primarily lived on the reservation or rolled hills or tribal jurisdiction, and that was based on federal policy where we were confined to those areas by the federal government as they made their way across the United States. However, in 1953, Congress adopted the termination policy, and that continued through that decade. The result of that policy were programs to assimilate the Native people to American mainstream society. And that was because this was an issue that was affecting the federal government. And the hope was by assimilating us into the rest of society that we would just become that one big melting pot that we used to talk about not too long ago, and the Indian problem would not exist anymore. And when I used to hear about this time frame, during this time period, my grandparents were frequently traveling to Washington, D.C. For these discussions to find out exactly what this meant and how this would impact us. Well, one of those policies was the Bureau of Indian Affairs Relocation Employment Assistance Programs. So it was a method of enticement. This was a luring of Native families who were living on the reservation to relocate to specific cities where these relocation programs were going on. At that time, my family was on the reservation in South Dakota. And so my mother talks about living in a wall tent during that time. My mother is a teen mom. She is not much older than me. So she is 62 years old. And she was raised either in the cabin setting that I pictured in that first slide, and then in a wall tent on the reservation, Pine Ridge Reservation in South Dakota. So I don't know how many of you are familiar with the Dakotas, but those winters are long, cold, snowy, they are hard. And so I grew up hearing stories of her having to go and take the axe and break the ice on the creek in Wounded Knee and haul the water to the wall tent or to the cabin. And so once again, that was the 50s. When my grandfather and my grandmother would visit, they would talk about the hard times. So having children growing up that way and understanding as loving parents that hardship that was created for the children. And so during that time, knowing that the unemployment rate in Pine Ridge was very, very high, getting a job, having income was critical for my grandparents. And so my grandfather talks about how he was sent to California for specific training. However, that not only occurred, and my apologies for misspelling, that should be a note. It's on the big screen, it's so much easier to see. My father was also part of the relocation program. So I was born in the later 1970s, just after the American Indian movement and the siege at Wounded Knee and occupation of Alcatraz, all of that. we were living in Rosebud, South Dakota, and my father was then relocated to Salt Lake City. They took the whole family. So when we were relocated to Salt Lake City, they sent him for carpentry training, and we lived in Salt Lake City for a short period of time. But you can see part of what this enticement method was appealing to people who were in severe poverty, who had very little, and offering job training, job placement, housing, and health care. And it came full with flyers that they distributed. So these are two examples of flyers that were distributed around that time. And so you see this one says, "Come to Denver, the chance of your lifetime, good jobs, happy homes, training." And then we have the Chicago Indians, get good jobs, show know-how. So these were all part of what helped entice not only my grandfather, but then my father and our family. What they did not explain is that these were very short-term, that there was an expiration date, and there was no contingency plan of transitioning families from that. So when we were in Salt Lake City, my mom and my dad used to share the hardship of him going off to work and my mother trying to keep us together and keep us busy during the day, because we lived first in a sort of a tent community, and then we were able to get a room above a store shop. But she used to talk about riding the buses all day long to keep us busy, because it wasn't safe for us to be staying where we were at while my dad was at work. And she used to talk to us about saving money. She would get laundry money from my dad at the end of each week. And she would talk to us about, okay, we have 10 cents. She would see 10 cents every week. And she would grill us on what can we buy with this much money. If we have this, what are you going to buy? And we would go through a loaf of bread, hot dogs, peanut butter. She would talk to us about why. Why are we going to do that? Because that will stretch a long ways, and we will get protein that we need, and we will have something to eat. So this is the way we lived until she just could not handle it anymore. It was a tough existence. I remember doing a lot of walking and a lot of crying. And so she was holding my hand. She was a fast walker too, so that didn't help. But my grandfather and the rest of our family in Pine Ridge and Rosebud pulled together, and they sent for us. And so we were able to go back home. Well, what this does not explain is that we have a very large extended family that is a support network to us. And so when you remove that large extended support network and you place a family in a large city like that, and then you cut off all the resources, the isolation becomes overwhelming. And to move from that to then continue with good jobs, happy homes, and training, it really doesn't pan out that way. So during that time, we had over 160,000 American Indians, Alaska Natives relocated to the urban centers. Once again, that continued all the way through to the end of the 70s. However, in the 60s, we had urban American Indian leaders who began advocating at the local, the state, and the federal level, especially in places like South Dakota. In 2010, the U.S. Census shows that 71% of our Native people now reside in urban areas. So the impact of that federal policy, where my grandparents and great-grandparents told those stories of traveling back and forth to Washington, D.C., having decisions made for our people and having several generations of my family affected by a federal policy to relocate, and now us being in an urban area is part of the example of that movement of our Native people into the urban areas. Now, when those tribal leaders spoke up in those urban communities, it was to address some findings. That isolation was creating barriers to health care. And so the information that was returned after assessing those people impacted in those communities showed that the health issues were no different than if they were still on the reservation. And some of those barriers that were identified were culture, economic, and access. And so that's really surprising when we look at access. So one of the things that I had done when I first had come on board to the Missoula Urban Indian Health Center is to explore, at that time we were education outreach and referral only, but to explore how other urban Indian health programs had been able to connect people to health care. Well, what I learned was that many of those communities that had a partnership health center or a federally qualified health center were already saturated. And so to be able to also absorb a Native population was above and beyond what they could already support. And so that was one of the driving forces of moving towards having the health care provided at the urban Indian health centers themselves. But what that finding did was it helped to make some changes at the congressional level where we had support, monetary support. So this is funding that was passed through legislation by Congress to enable these urban Indian health programs to get started. So part of history that we have to talk about oftentimes is a dark past. And so some of the things that impact when I interact with families today is a series of occurrences that have happened over history that continue to be passed down through oral tradition or firsthand experience of family members where mistrust has been created. So this particular slide just goes over smallpox. Was this biological warfare? Was it not? We don't know. What I do know is that on the Blackfeet Reservation in Montana, our Umskapi Bikani, that's the southern Blackfeet, so those are the Blackfeet people here in Montana. And just to clarify and expand on that, we are part of a confederated Blackfoot tribe. That confederated Blackfoot tribe includes the rest of my family, the Bikani, who are in Brockett, the Kainai, so those are the blood, the Siksika, and a fourth band of Blackfeet that are all part of a larger confederacy. So oftentimes we're very much connected via relationship, culture, language, and then also traveling patterns. But my particular band is very small. So the enrollment of my tribe right now is just hovering over 4,000 Bikani people. That's it in the world. And so we continue to see that our growth pattern is not very robust. But when it comes to recircling back to smallpox, at the turn of the century, the Blackfeet Nation almost reached, their nadir. So they were almost completely decimated by smallpox outbreaks. And so growing up, my grandfather used to like to take us on drives through our reservation, and we would oftentimes travel along the creek sides there, and he would show us and point out these pits And they were about as large as this room, but they were just these sunken circular areas where the military had dug mass graves to put in and bury our people with smallpox. So the smallpox was something that growing up we were often told this was something that was given to us to get rid of us. And that was the belief. Now whether or not that is truly connected, I don't know. We don't have the evidence for that. But what we do have is we have a history. We have Lord Jeffrey Amherst, who sent letters to Colonel Henry Bouquet. I don't know if that's the right pronunciation. But in one of those letters it states, could it not be contrived to send a smallpox among those disaffected tribes of Indians? In another letter it said, you will do well to try to inoculate the Indians by means of blankets, as well as to try every other method that can serve to extirpate the execrable race. And then we also have evidence that a captain at Fort Pitt, Pennsylvania, that same year, did give 2 infected blankets and infected handkerchiefs to the tribes there. What we also know is that smallpox was something that moved across the United States and had a tremendous impact on the population of our people, as noted by those sunken pits here in Montana that we continue to show our children and our grandchildren. These are 2 samples of those letters as evidence of the smallpox idea. So not only that, this is December, and December for my family is always a very difficult month for us. My family, I am a direct descendant of the Wounded Knee Massacre with Chief Bigfoot. I'm very thankful for the survivors. There was a young girl, Lucy Lasthorse, and then a young boy who survived the massacre at Wounded Knee. Right now, as in a few days ago, our families on the Pine Ridge Reservation and also across South Dakota began their annual journey in memorial of the survivors of Wounded Knee. And they will make the trek across the South Dakota. They are doing that now on foot and on horseback to be reminded of our resiliency and our survival and part of that healing journey. But this is a picture. And so growing up in South Dakota, living all together, the evenings were story time. And so every winter I would hear my parents and my grandparents discussing the story of the survival of our family at Wounded Knee. And they discussed this particular church. So this church is in Pine Ridge, and you can see the direction, the decorations, because this was just after Christmas time. Our family survivors were rounded up, and you can see that they were put on the floor here, which is covered in hay, and you can see the word hospital. So for my family members, this would have been their first introduction to Western medicine. The next piece here are boarding schools, and these boarding schools are where my grandparents went to school. So this one here is Holy Rosary Mission, which is right outside of Browning, Montana. You can still go there. It's primarily going to be brick foundation around there, but growing up we would often be driven there, and my grandfather would tell us stories about his time and the many times he ran away from Holy Rosary Mission. And this one here is in South Dakota. So this is in Rapid City. You can see the girls here and the boys here at school. The title of this one, From Boarding School to Sanitarium. So boarding schools established in 1886 by U.S. government under the Bureau of Indian Affairs housed a lot of children. And at this time, my grandfather will attest to this, they were very crowded. This was forced removal, and so we're talking about my great-grandparents, my great-grandparents, my grandparents, my parents, myself, and my brother. My children will be the first generation who have not attended these Native boarding schools. During that time, disease, illnesses were frequent. And so we understand today that our Native people have tuberculosis, even latent tuberculosis, at a high percentage as compared to other races. And so it's one of the things that we recognize, and still today it's something that we understand is connected to the boarding school eras. So this particular school turned in from a boarding school to Sioux Sanitarium, which was the sanitarium only for American Indian people. And my grandmother went to the sanitarium. Her friends, she had friends in the sanitarium, but this was not a place to get well. This was a place where you were sent in isolation, quarantined to die. Now, they closed the sanitarium and they turned it into the Urban Indian Health Program. However, that has recently closed down, and now I think that they are either trying to save it or build a new facility. But these are experiences that have been very, very powerful on our Native people today, and also tied very much to where we are at today. So when I talk about the boarding schools not being very long ago, we saw grandparents, parents, those are my uncles on my dad's side up in Rocket, Alberta. This is my brother and I right outside of Missoula. And we are probably getting into all kinds of trouble. So one of the things that is really, really important for me is building rapport, building trust, because we have mistrust based on real examples of experience. So you can see this when I was last lived in Pine Ridge, which is in 2000. We had a lot of issues with Indian Health Services at that time, and I absolutely believe in the work that Indian Health Services has done in this last decade to turn things around. It is not perfect. They are severely underfunded. I didn't include that slide, but when we look at per capita funding, we know that every single other federal program is funded at a much higher rate than our Native people. And so that means that if we were incarcerated, we would have better health care than we have according to the funding levels through Indian Health Services. But dealing with a shoestring is what we are used to. And so one of the things that has been very powerful is to see our own Native people empowered and take control of their own healthcare system through the tribal 638s like Salish and Kootenai Tribal Health. That's not too far from us. But at this time, this is in front of the Rosebud Indian Health Services, and then I was often seen at the Pine Ridge Indian Health Services. So when we walk through time, this is 1970s. My grandmother was a nurse, and when my mother got pregnant, she asked her not to go to the Indian Health Services, and she asked her to decline any kind of prenatal care there. And it was because she was worried about what she was hearing. When I heard the stories, to me it was very hard for me to understand why my grandmother would say not to go there. But my mother would always tell me, Grandma Lolly always said that I wasn't supposed to accept this or accept that. If they wanted to do this or to do that, not to do it. And when I went back to Pine Ridge for my womanhood ceremony, when I was a 13-year-old at the time, we went to my mom's best friend's in Wounded Knee, and she said, I'm a midwife now because we don't send our women to the hospital to have their babies. You're going to see that we have lost a lot of infants at the hospital. Well, to me, that was another message. Okay, I have to be very careful, and my trust for healthcare was affected by those interactions. But these are part of the policy of our federal government. So Indian Health Services, we ended up finding out in the 1970s sterilized women, Native women without their consent, including the IHS facilities where I was born and where my mother received care. You can see this one. You might not be able to read it very well, but it says, she, Connie Urey, scoured the records of the BIA run Indian Health Service Hospital in Claremore, Oklahoma, and discovered that 75% of the sterilizations were non-therapeutic. Many of the women did not understand the true nature of the surgery, though it was kind of, and it'll go on. And this was an article from 1978 with our Native leaders protesting the sterilization, which once again, another federal policy. So one of the things I also talk about is loss, and that is because whenever we do anything with programming, we're mindful that there is a process of healing that is taking place amongst our communities to address a lot of these experiences that have been occurring generation after generation after generation without a recovery period. And once again, when you have great-grandparents who did not receive parenting, grandparents who did not receive parenting, parents who did not receive parenting, on and on, generation after generation, we understand that there has been significant trauma, and generational trauma is something that we are mindful to tie into our health programming because we understand there are trust issues that continue today. So this is a picture of me and my sisters. All four of us are actually first cousins. All of us lost a parent. And then even with my family here, we talk about missing murdered Indigenous women, and we're all impacted. Crystal Gale, her mother died when I was probably about 3 years old, and then when I was 25 years old, we learned that she was found in a field in Edmonton. And so we do not know how she passed away. My cousin, who's also here, she went missing when she was 14. And we were able to, my uncle was able to find her in Calgary, and she had been taken by a man, and when we brought her home, she was pregnant, and she was my very first experience of having firsthand a stolen sister. But through all of that, we are resilient and we're still here. And so even though we are only 4,000 in the world, we are a young people, and that's one of the things, knowing that our life expectancy is decreased. When dealing with programming, we also understand that we're dealing with oftentimes young families, and a young population, with a third of our population being 25 years or younger, and that includes in Missoula. And understanding that we have that shift that occurs between 30s and 40s where we suddenly have more women than men because we lose our men in their 30s and 40s. And then we have another shift that occurs where we then see a decrease in our people becoming elders. But what this is to show you is that with my own family, the majority of us are women. We are young. This is actually, it's hard to see, but this is the roles for our community, and those are our names in our native language. And so my family's name is Crazy Boy. And so that's one of the other things that's also oftentimes something to be mindful of, is that as Native people, we may have very different names, but to us they tell a very powerful story. To other people outside of our culture, oftentimes it's something that they find almost humorous. But being mindful of how, when we hear those names, how we react can shape that trust relationship that we're trying to build with other people. Because I've been in areas where healthcare providers have talked amongst themselves and been overheard by family members discussing names that to the outside world may seem very funny. So not only with this one, we also see that, so my grandmother was a teen mom as well, and she had 13 children. Of those 13 children, I only have my Aunt Judy, my Aunt Beverly, my Aunt Beulah, and then my Uncle Mark. My Uncle Mark is just a couple years older than I, but those are 4 children out of 13 children, and my father was the oldest. And so understanding that life expectancy issue has been very powerful for me entering into the work that I do. But this is where ACE comes in. So adverse childhood experience in the CDC Kaiser Permanente ACE study was able to demonstrate that adverse childhood experiences affect disparity. And so that not only affects health outcomes, but we see that when we have adverse childhood experiences that can disrupt neurodevelopment, it can impact social, emotional, and cognitive function and development and lead to impairment. We understand that all of these things compound in our adoption of risky behaviors that can then also impact outcomes. And we understand that disease, disability, social problems increase with higher ACE scores, which in turn can lead to early death. When I roll back here, all of my aunts and uncles were raised in foster care and then adoption. And so understanding also that all of those things have affected a number of other families, where does that lead? That's where we try to be mindful of other people's experiences and where they are today. So this is an actual question that was on an exam in New Mexico. My mother is an English teacher, and this was one of the state questions that was asked for her 4th grade class. So use an order of magnitude to find the answer. A doctor's waiting room contains how many people? So the first selection says 1 to 10, the second says 20 to 30, and the third one says 50 or more people. So what was the right answer? Anybody? Wild guess.
Had you been in a waiting room? 1 to 10.
1 to 10 was the correct answer. What did, well, let's just go to the next. So this is, and it's funny because I can't find current pictures, but what I'll tell you is that growing up, this was my experience. When I would go to our Indian Health Services in Pine Ridge or Rosebud, it was a long, long waiting time. This is the line at the Blackfeet IHS Pharmacy. And so when it's much improved now, once again, time has changed, and so things are definitely changing. But at that time, we could have a lot of people in line. We were often very, very behind in being able to get prescriptions out to people. But what I compare it to is this is the line at the DMV. And so, this picture, my children oftentimes send this to me for fun. They say my waiting game is strong. And I say, well, this is the way I was raised. Indian Health Services waiting room. Like I said, it's not like that at all facilities. We do still have facilities that are struggling, but this is a reality of our experiences for those of us in certain areas. So the answer that every single student in that 4th grade class chose was 50 or more people, and every single student got that question wrong because their point of reference was Indian Health Service. Here is a map of Montana, and on here you will see, so black stars are Indian Health Service facilities, yellow stars are Indian Health Service station clinics, and then green stars are compacted tribes, tribally operated health. We have 2 in Montana. We have the Confederated Salish and Kootenai Tribal Health, and then we have Rocky Boy. The reason I want to show this to you is because you will see that the closest IHS facility, which is open to our federally recognized people, is all the way near the Canadian border. And so before we became a clinic, many, and still today, our people here in Missoula are driving all the way to Browning to receive direct care services. And that includes prenatal care for prenatal visits. And we know that going through Glacier during the winter can sometimes be closed. Growing up, knowing that we would have snow slides on the way, things like that. But then the next closest is going to be Crow. And so even with Crow, knowing that their labor and delivery was closed some years ago, we still have families that will go into labor here in Northern Cheyenne area because they also did not have labor and delivery, and traveling to Billings and not be able to make it to Billings as they were preparing to deliver their babies. And so the reality is that when we look at Confederated Salish, Kootenai, and Tribal Health, because they are tribally owned and operated, and because there is a limited budget for each IHS facility and tribal facility, they very much want to make sure they prioritize their people onto the reservation. And so historically, our access has been limited if we are from another tribe. We're able to use their pharmacy services as long as we're enrolled in a federally recognized tribe and we're registered there. But otherwise, the limitations for how we access services can be very far. So how do we build trust? We're going to move to the happy part. That is where cultural humility comes in. So being able to learn, acknowledge, and understand. Now we understand that as Native people, going through a lot of the experiences we went through, that not only has changed how we see healthcare and how we respond to even taking care of ourselves, but also in how our healthcare providers see us. If as healthcare providers we're not informed on what those barriers are, we may not recognize them. And if we can't recognize those barriers, or we have an ignorance to those barriers, it's going to be very hard for us to really be able to make those relationships and be able to create safe places so that we can create new interactions. As Native people overall, I will tell you that our experiences become the way that we survey what is safe, what is not safe, and then transfer that information to our community. And so the word of mouth and our experiences in that first interaction with a provider may have far-reaching effect through the large families that we have. So every interaction is an important interaction. But as Native people, I like this picture because you can't always recognize who we are. I have a little brother who has blonde hair and green eyes, and he speaks fluent Lakota. He's a spiritual person, but once again, if you were not part of our community, you might not identify him as Native. I also have family members who have been raised in the city who do not know their language, have no ties to their culture, but very much look Native and yet don't identify as much with the things that people may stereotype a Native person being. So I will always use these three statements with my students, and I find that they are very, very helpful. We look at ourselves and where we are, and we look at the other individual across the way, and our whole goal is to have this bi-directional flow of conversation, communication, and information. How do we create that bi-directional flow? That individual may have their own bandwidth. They may not be in a place where they're able to receive everything that we have to give. So we need to be able to have the ability or the skill to create a place where we can reflect on, okay, this is who I am. What am I bringing to the table, and what do I need to set aside so that I can really concentrate on identifying who this person thinks that they are and what they're actually going to be willing to share with me. Our biases, whether they're explicit or implicit, shape our attitudes, our assumptions, our generalizations, our stereotypes. We're born with them. We walk a certain life path. They're there, okay? But how do we just create that space to take a pause and identify, yes, they are there? Me as a Blackfeet and a Lakota woman, I know that the way I think is shaped by those experiences. And when I meet someone new from another culture, I have to be mindful that where I'm at and how I think may either create a conversation that is able to grow a relationship or create a wall. And so how do I prevent that wall from going up? And that's where cultural humility comes. It's that self-awareness, that self-reflection. I am not the expert for the person that I am interacting with. They are the expert. Well, I might have all this information, it is meaningless if they're not ready, if they don't have that bandwidth to receive the information that I'm trying to send. So we learn from the people we serve, and we acknowledge what is important to them, which may not be what is important to us. By doing that and recognizing, we're able to remediate how we then formulate what we're going to send across. And that's how we reframe those interactions. So making the connection. Yes, history, culture, identity, federal policy for our Native people. It's a dark path, but it's a truth. And it is where we have to go to understand where we are today and make the changes that need to happen. Questions?
So I have a question. So I have Native Americans in my family as well, and have heard a lot about the forced separations. And from my limited understanding, that was incredibly disruptive and impactful. But it also was very different depending on where you were. So some families had visiting privileges, family days, those sorts of things, and others were extremely abusive, punitive. Is there any sense of what happened in Montana versus some of the other per tribe, or was it one-on-one kind of? Because I mean, this was, you know, years and years, you know, depending on, and a lot of that was Catholic ministry and conversion and things like that. And just kind of interested to know your perspective about I'm from Eastern Montana, so I'm kind of interested in what you know about Eastern Montana too.
So what I can tell you is that if we look back at the last 120 years, we understand that within each community, there has been impacts by boarding school, by child removal, or by even social services in recent years, and with the Indian Child Welfare Act, on how different situations were handled. There is no one size fits all. And so what one story is can be very, very different than another, because as you had mentioned, some experience could have been very abusive and very damaging, where others could have been very positive. And that's the same for my own family. So when I look at Eastern Montana, and my children have family in Crow, and so a lot of their members also were sent to boarding school, were sent to foster care systems and things like that if they were removed. It has been all over the place. So there's no way to say isolated in certain communities. It really depended on the individual family. I wish that what I wish is that there was actually more information. And one of the things that is the reality is that data here in the United States is missing. If we look at Canada, we have more data. If we look at Australia and their work with Aboriginal people, there's a lot more data. But in the United States, especially when we look at areas of what has happened with children, what has happened to shape where we are at today, there is just nothing. So that's part of the work, and that's the part of the work where we look at our allies to help to speak up and share, okay, how are we measuring the segment of our population that is dealing with a lot of these disparities, and recognize that as Native people, we are not just a race, we are an actual political classification. Yet this political classification has almost no data. Any other questions?
So I was fascinated that you said a third of your population is youth, and I'm just curious, how are the youth doing?
So once again, knowing that data is limited, I can only share here's an example. So I do site visits all over Montana because I place students all over the place. One of the places that I place students is at Shodare Children's Hospital. So Shodare Children's Hospital is inpatient, and we understand that in Montana, well actually, we understand. What is our population for Montana for American Indian people?
It's like 17%.
So no, in some communities it would be 17%, but it's around 8% around there. Okay. And for Missoula, we're at 4% if we include people who also identify with other races and American Indian. We're a little over 2% when it's only American Indian by itself. At Shodare Children's Hospital, their service population is over 16% American Indian from Montana. So that's disproportionate. When we look at our incarceration rates, those are also very, very high. When we look at the data for missing murdered Indigenous women here in Montana, extremely high. So when I look at these things, I understand that the limited data that is there shows that there is a significant disproportion in things that are affecting our youth. And that includes when we look at basic things like nutrition and even when we look at the public schools and education. We're making tiny gains, but we still have a long ways.
Do you know if there are any bills in the works now in front of Congress to increase healthcare spending for natives?
There is not. So that's a whole nother presentation where I go through just what it looks like. What I will say is that this particular president has not been worse for the wear when it comes to funding. When I first came on board in 2010, we are protected under the Indian Healthcare Improvement Act. That is critical, especially for the urban Indian health programs. For a very long time, almost 20 years, the Indian Healthcare Improvement Act was not reauthorized, and we were on the chopping block every year, especially under the Bush eras, because that was funding they could use for other things. During that time that I came on board, there was a freezing of funding for urban Indian health programs, for instance. And we share a pot, so when Indian Health Services receives their funding appropriation, then that particular appropriation is then broken down. And part of who helps to decide how much, even for our urban Indian health programs, get, our tribes also contribute to that decision. And so one thing that has been really amazing is that in the last 2 to 3 years, for instance, the Crow tribe is very much supportive in giving up part of their funding to help support the urban programs in Montana. But that's not necessarily getting more program, it's saying we'll do with less so that these populations can do more. There were rescissions, so 2010, 2011, 2012, 2013, 2014, there was 0.2% rescission, 0.2% rescission over and over and over again. So I would say we're flatlined. The last time I went to DC, I was told you will not receive more funding through congressional appropriation. That's not the mindset that is going to get us there. So we have to be creative, and that's where being able to help our Native population understand eligibility for expanded Medicaid, for the marketplace exchanges is critical, because there's specific rules that help to increase their ability to enroll in exchange plans where they have a decrease in how much they will pay out of pocket or for deductibles or for their premiums.
Have you had the opportunity to present in front of Congress like you presented to us today?
Only to our, so our leaders here in Montana will send their people to Missoula Urban Indian Health Center. Whenever I get them, I have about 5 PowerPoints that I'm ready to pull at any time, because what I find is that the rest of the United States is unaware. They do not understand. And the reality of it is that unless there are people who do understand, who can advocate, then they're not going to understand. So they did ask for a presentation to be sent there, but I'm very careful about sending anything with someone who might
misinterpret. Totally.
Right. But but it's important. So, for instance, running the special diabetes program for Indians. That is it's a population health program that has made a tremendous difference in the landscape of diabetes in the Indian country. And so we have seen a significant decrease in the incidence of diabetes for our Native people, but we have also seen a decrease in end-stage kidney disease, in vision loss, and we're seeing a plateau when it comes to obesity rates climbing. It's a tremendous and powerful example of what funding can do when given to tribal people, because now is the era of self-determination. And that means that we have a say in how our health care is provided, and we can make those changes.
First, I'd like to say thank you so much for being here. I could listen to you for days. So,
I'm already over.
thank you very much. What other resources would you recommend, books, places to go that would be like in your perfect world? You're like, this is a book I want the entire world to read.
Right.
What would you recommend?
So there aren't books out there, so to speak, yet.
Okay.
But what I always would recommend is to go on to the Urban Indian Health Institute. Take a look at, they have a wealth of research sources. So that's UIHI. And if you Google it, you'll find it, Urban Indian Health Institute. The National Council of Urban Indian Health also is a tremendous resource. I have been trying to get Dr. Warney, Dr. Donald Warney from North Dakota, to come to Missoula to present to our medical community. He is extremely popular and high demand, but that is a person who is able to really line out in a very clear 60-minute concise piece all policy from the USDA food system all the way to things like WIC and tie together where we've been, where we've come from, where we need to go, and how we're going to affect change. So if I were to look at anything else that is available, if you go onto the UIHI and you go onto NACUI, that's the National Council of Urban Indian Health, they will have links where you can find additional resources. But those are my go-to places.
Great, thank you.
Sharon? Yeah. When you brought up the missing and Indigenous women, I happened to go to an evening workshop, and they talked about a book called The Beginning and the End of Rape by Sarah Deer, and I'm in the middle of it, and it's really powerful. I think that speaks to that portion of your talk.
Thank you for sharing that. I haven't read that, and that would be really powerful for us to share as well. So I'm going to remember that. And did you all hear? So Sarah Deer is the author for us.
And it's available even on Kindle. If you like to read. What is it called? The Beginning and the End of Rape. And it has a lot of statistics in it. A lot of fact.
Anything else?
Do you mind if I jump in?
Please do.
I want to thank you as well. It's so good to see you again. And to speak to your question, Steve, because as a non-Native person working for the Missoula Urban Indian Health Center, I think an important thing to recognize is while it's awesome to have resources like Jareth and to have been welcomed in by so many coworkers who literally just daily were helping me learn, it's important that we do our own homework as well and don't, lean on people to tell us their own. It can be hard for people, and I think Jareth's really brave and an incredible resource for our community in doing this, but not all people are at that place, and so it's important for us to do our own research. And so for me, one thing that I would recommend is there's a book called The Indigenous Peoples' History of the United States by Roxanne Dunbar Ortiz, and it's a pretty dense read, but it's like 250 pages that tells you basically what your history books should have been telling you in 4th grade social studies about things that are still called battles that were truly massacres, and it's important for that identity work of acknowledging the truth of our history and sitting with it. And then I would also just say, the events that the Missoula Urban Indian Health Center holds are not just for clients at the Missoula Urban Indian Health Center, and that's the other huge piece of what we're talking about with this is being in relationship with one another. And I happen to have been privileged to have that experience, to be so welcomed into that community, and I feel really passionately about it. So I hope that you all, whatever social media you use or what have you, will just go to the Missoula Urban Indian Health Center, start to be in relationship with that piece of the community, and go to events. And because I think sometimes we do a lot as a health department or as government when we want to bring a diverse group in, we want to reach everybody, but I think we also can do a lot personally to show up in other spaces and say we're here to support this as well, not just ask you to come to our stuff. So those are just the only things I wanted to add.
That helped remind me, if you're looking at, for instance, a personal story, Madonna Swan, she was one of the patients at the Susan Tuberculosis Sanitarium. So Madonna Swan is an excellent read on her personal experience.
Luana Ross too. She's from Montana.
Yes.
She's got a lot of great articles out about incarceration of Native people in Montana specifically.
Absolutely. And just as Hallie had mentioned, we keep our Facebook and our website pretty up to date. We have a very thriving and growing group of individuals who are addressing a lot of different areas, from MMIWG+, to looking at incarceration rates, and also just working on really connecting with the community. I will share that every spring we have our Missoula Urban Indian Health Center Spring Wellness Fair, and the entire goal of that is to be able to have a showcase of community resources where our Native people can go that is non-threatening, so that they can meet with different organizations. Our population is small, so there may only be 50 people there, but I will tell you, once again, the way that we evaluate and the way we share data is by those experiences in our smoke signals. Anything else?
I just want to thank you, Cherith, for finding the time in your super full schedule to come and share your experience with us. And
I so apologize for...
It's okay, you made it.
I made it.
This was amazing. I'm not getting home though.
Well, I'll make sure you get your car starts, and I got jumper cables if not, so, but that was beautiful.
Thank you. And please, if you're ever in the neighborhood, you can always schedule, a visit with us, or even just stop by and visit. We're very, very open to